Thank you, Mr. Chairman. Let's start. Well, let's start with a little bit of philosophy. If we consider a metal chain, we see that it combines the strength of solid metal with the flexibility of rope. We can use this as a model for how modern diagnostics should work. Arriving at a diagnosis isn't a single event, but a process. So one link leads to the next and defines it. The problem with chains is that they're only as strong as their weakest link. Radiographers are responsible for two major links in the diagnostic chain. Technique, that's how we provide diagnostically useful information by at the same time also reducing risk to patients. And the second is quality assurance. I'll be focusing on this link today, specifically on how we do quality checks of spatial resolution in plain radiography. In the past, quality checks were done by visually assessing developed films, which was a subjective method which had a lot of uncontrolled variables. Today this process has moved into the digital environment, but it still utilizes quite a lot of subjective assessment, so it's only partially digitized. In the future, digitization will improve, perhaps culminating in quantitative quality assurance, which may enable standardization and broad interoperability. Our goal was to develop and deploy a preliminary software solution for automated, consistent, and quantitative characterization of an imaging system's spatial resolution. In other words, to replace a subjective assessment by the use of a measurement tool. We used an ETR test plate, a Siemens Multics Vertex system, AGFA CR cassettes, and an AGFA scanner. We performed two series of exposures, the first one with the small focal spot and the second one with the large focal spot. All of our exposures conformed with QC guidelines, and parameters such as SID, tube voltage, MAS, FOV, and the matrix size were held constant throughout. We did 20 exposures with each focal spot at 20 different z-axis positions for a total of 40 images. And we moved the test plate by 20 millimeters towards the cathode side between exposures. We developed a pilot ImageJ macro to carry out automated characterization of the line pair segments. And just to give you an idea of how that works, we mocked up a demonstration version. So we open an image, zoom into a visible landmark, in this case X, import our macro, give it the position of the visible landmark by clicking in the middle of X, and then the program automatically segments the spatial resolution part of the phantom and measures each line pair segment while recording the results. The results were then used to chart an approximate modulation transfer function curve for each exposure. And in order to compare this with the existing method, we asked 3 radiographers to estimate the limiting spatial resolution of our system. We did this by manually segmenting the spatial resolution part of the phantom, exporting it as an image. We randomized the images and presented them for assessment on a diagnostic workstation in a lightly dimmed room. Our results take the form of 2 spreadsheets, one for each focal spot. They have 20 different rows and 19 different columns. So the rows correspond to the different frequencies that are in the test plate, and the different z-axis positions are in the columns. The spatial resolution was clearly visible in the first series at between 3.1 and 3.4 line pairs per millimeter, and after we applied a threshold, it was visible in the second series as well. The values which we got from our assessors, however, they diverged significantly from the normal distribution, so we used a non-parametric one-sample Wilcoxon test to analyze them. We found that the values of each radiographer significantly differed from the overall mean, and each radiographer's values, as well as the overall collection of assessments, differed from the 3.1 to 3.4 range defined by our macro. According to the Nyquist-Shannon sampling theorem, our actual limiting spatial resolution was approximately 3.3 line pairs per millimeter. This is consistent with what our macro produced. It, however, differs quite significantly from the results put forward by our assessors. In short, our macro's performance was significant to the existing method. In conclusion, our pilot program consistently produced a comprehensive quantitative characterization of imaging system spatial resolution throughout several images and using different focal spots. We suggest that widespread deployment of performance measurement software would make it possible to do useful comparisons of imaging systems between different hospitals and in other interesting situations. If we return to our original metaphor, we think that the link in the diagnostic chain would be strengthened. In addition, quality assurance data would become useful for applications outside diagnostics, so links could be forged outside of current possibilities. Thank you.